Okay. Good morning, everyone.
Good morning, everyone. Welcome to this morning's meeting. This morning, Divya Ramyead, Registrar at UCT, will be presenting. Please keep your microphones muted for the duration and just unmute yourself if you want to answer a question or ask one. And Divya, over to you. You can go ahead.
Thank you, Garrett. Good morning, everyone. Today, it's with great pleasure and excitement that I will present an interesting pediatric case, that of a granulomatous nasal lesion. The history goes a 3-year-old female from Kalicha presented to our hospital with an 8-day history of right facial swelling, 2-week history of runny nose and itchy eyes, following an enlarging and painful skin lesion over her nasal tip. She had no past medical or surgical history, no history of trauma, an uneventful perinatal history, and she lives with her grandmother. On examination, this is how she looked. Will anyone like to describe how this lesion looks like? Maybe with the exam candidates?
Hi, Divya. Thanks very much. It looks a little bit erythematous over the tip of the nose and the bridge of the nose, but also quite swollen, like probably edematous and sort of patchy edema. And then it looks like there might be an orbital asymmetry as well, possibly.
Yes, indeed. So on nasal examination, there was an external swelling over the lower two-thirds of the nose, sparing the nasal bridge. There was also a right facial swelling, as you correctly noted, with a right vestibulitis on internal examination. Her eye examination, initially when she presented, there was mild right eye proptosis and swelling around, but full range of eye movement and normal visual acuity. Other examinations like the neck, ear, oral cavity, and throat were unremarkable. So what investigations would one proceed to ask for in such a case?
I'm happy to. Hi, Divya. It's Gerrit here.
Yes.
So taking into account probably as the topic of this meeting is going into granulomatous lesions, one would investigate for that. First investigations one can consider is blood tests,
Yes.
specifically full blood count, taking into account a raised white cell count.
Yes.
Then ESR and CRP specifically.
Yes.
Then one can go on to, in our population, I think HIV and TB go hand in hand. So it's important to test this kit for HIV.
Yes.
And then do exclude syphilis on a VDRL or RPR as well. I don't think autoimmune causes come more into play in adults, but maybe ANCA and ACE will be of value just to exclude those. And then going on to imaging, I think a CT paranasal sinuses will be a good first line, but also taking into account just a chest x-ray to exclude pulmonary lesions. I don't think MRIs, depending on what the CT scan shows and further investigations, one can consider MRI.
Excellent.
Can I just interrupt you? I think just for the exam purposes, I would be very careful about mentioning things like anchor, because first those tests cost a lot of money, and secondly, it's an inappropriate test in a child of this age.
Yes.
So unless you, I don't know all the rest, but this is not going to be rigorous, is it? No, I'm asking.
I'm not sure. I don't know what this case is.
It's not the right age group.
Yeah. It's unlikely to be. It's highly unlikely.
Highly unlikely. I think one has to be
specific.
No, it's literally not a list of investigations that you think of everything that's in your head.
It's
your
specific to.
Investigations has to be targeted what is most likely, and that's where you start off.
Yes.
I think just from a cost point of view, but also from an exam point of view. The other thing is, Divya, in your presentation, you said that I was normal. It didn't look normal to me. She had a clear ptosis, only half of her pupil. If you go back to that slide.
Yes, she had ptosis, but the full range of movement and visual acuity was normal.
Yeah, but you can't say it's a normal eye examination then, because you have to be able to explain the ptosis. Only half of her pupil is visible, so she's got a clear ptosis.
Yes.
Yep. If the child can be having a chest X-ray anyway, TB and so on, would the sinus X-ray not be adequate? Because if the sinuses look normal, not aerated, then you probably won't have CT because it's really soft tissue.
We can't hear you, Prof.
I'm saying that if the child going to be having a chest X-ray done anyway, you could just have an X-ray of the nose and parasalos, the sinuses, because if that's normal, then you probably wouldn't have to proceed to a CT scan. You then just talk about soft tissue.
Yes, Prof. So in this case, as Garrett said, we did the baseline investigations, which included FBC, ESR, and HIV. In FBC, the WBC, the white cell count was normal, ESR was within normal limits, and HIV was negative. Her blood culture showed no growth. Her chest X-ray was unremarkable. There was no TB lesions noted. Her Mantoux test was negative, COVID test negative, and a CT scan of the paranasal sinuses was done. And the findings were, as you can see on the left-hand side of the coronal view, an all anterior maxillary wall and orbital wall fracture was noted on the right side. There was facial cellulitis noted, but with no drainable pus. A normal CT brain was present, and opacified maxillary and ethmoidal sinuses, more on the right than on the left, was noted, as we can see on this axial view of the CT scan. So as initial treatment, we proceeded to start her on analgesia. IV augmentin was started for the first 3 days and then changed later on to IV ceftriaxone 50 milligrams per kg 12 hourly. No steroids were started at this point. A Lodox was done just to rule out any fractured ribs or trauma, and a social worker referral was done to rule out non-accidental injury. On day 4 of admission, there was no change in the child's condition. There were no raised inflammatory markers, and we proceeded to do an EUA of the nasal cavity. On findings, we noted that there was a deviated nasal septum, lacerated nasal mucosa of the septum, and exposed cartilage. Granulation tissue and edematous mucosa was noted in the middle meatus, and the nasopharynx was normal. We proceeded to take biopsy and send it for histology and MCNS. On histology, diffuse lymphoplasmacytic infiltrate with histiocytes, ill-defined granulomas, and numerous multinucleated giant cells were seen, occupying mainly the dermis and the subcutaneous fat. While waiting for HP results, we proceeded to refer to rheumatology team in order to rule out causes like sarcoidosis, and they suggested an IgG staining of the biopsy. An ophthalmology consult was done in order to rule out vitreous hemorrhage. Dermatology consult was done, and they queried lupus vulgaris secondary to TB flare and Wegener's vasculitis, and therefore they suggested a skin biopsy also to be done. And infectious disease recommended to hold off steroids. On day 14, we proceeded to another EUA of the right nasal cavity, anterior ethmoidectomy, maxillary antrostomy, and biopsy of the inferior turbinate. The intraoperative findings were, we could notice, I will show you a video for this. Punch biopsies were also done over the nasal bridge, and specimens were sent for histology, MCNS, and special stains. But intraoperatively, we could see hemorrhagic mucosa lining the lateral and medial nasal wall, as well as a polypoidal mass was noted in the maxillary sinus invading into the floor of the orbit. Histology results came out showing dense chronic inflammation, showing lymphocytes and plasma cells with surrounding fibroblastic proliferation with extension into the bone and areas of necrosis seen. There was no evidence of inclusion, fungi, and malignancy, and it was negative for immunohistochemistry, myogenin, desmin, SMA, beta-catenin, CD34, and S100. These are tests that are done in order to rule out soft tissue tumor. The skin biopsies were sent for WHO HPE testing, and they showed admixed Langerhans type giant cells and focal granulomas, within which were uninucleate organisms with granular eosinophilic cytoplasm and small round nuclei. It was negative for PAS staining, Zeal-Nelson staining, modified Zeal-Nelson staining, and Gorodkot staining. These are stainings that are done in order to view for parasites. And but a protozoal etiology was diagnosed based on the uninucleate organisms. And it turned out that these were free living amoeba, Balamuthia mandrillaris. 48 hours later, the child's GCS dropped to 10/15. The child became drowsy. She had poor muscle tone and poor reflexes. Intermittent temperature spikes were noted, and an urgent CT scan was then ordered. The CT scan showed pachymeningitis, ring-like lesions, and frontal abscesses, as you can see pointed by the arrow on this axial view. This led us to diagnose the child with granulomatous amoebic encephalitis, as well as granulomatous cutaneous lesion caused by Balamuthia mandrillaris. We all know granulomatous conditions affecting the nose and sinuses can broadly be classified into infective causes, inflammatory causes, and neoplastic causes. This table is taken from the recent edition of Scott Brown, and it beautifully explains how the infective causes can further be divided as bacterial causes, most common being tuberculosis, leprosy, rhinoscleroma, fungal causes, including rhinosporidiosis, histoplasmosis, protozoal causes, including leishmaniasis, and now the rarer case Balamuthia mandrillaris, inflammatory causes, including sarcoidosis, Wegener's granulomatosis, eosinophilic granulomatosis with polyangiitis, cocaine-induced midline destructive lesion, giant cell granuloma, eosinophilic granuloma or cholesterol granuloma, and in neoplastic, we can think of extranodal natural killer cells or T-cell lymphoma. So just to brush up on what are the free-living amoeba that cause human infections, we've got 4 free-living amoeba, the most common being Naegleria fowleri, which causes around 300 cases of human infection worldwide. And it is followed by Acanthamoeba and Balamuthia mandrillaris. Of note, Acanthamoeba can also cause keratitis, which can lead to severe corneal infection and potential blindness. Balamuthia mandularis, as well as acanthamoeba, cause severe disseminated infections in the brain, leading to encephalitis. The life cycle of Balamuthia mandularis, it exists in two forms, as cis and as trophozoid. The trophozoid is the infective stage of this parasite. And how is transmission done is by either two ways, either through the nasal passages into the lower respiratory tract or through an ulcerated or broken skin. Studies have shown that this parasite has been found to be present over, this protozoa has been found to be present in dust and in mites, and also in dogs who stay in stagnant waters. Why is Balamuthia mandularis termed so? It was first isolated from a mandrill baboon that died in San Diego Zoo Wildlife Park in California in 1986. And following which in 1990, the first human infection was reported, hence its name, mandrillaris. The risk factors include Hispanic ethnicity, and by Hispanic ethnicity, we mean people who are from Peru, Mexico, Cuba, South America, and Central America, as well as Puerto Rico. There is a genetic predisposition that is seen, and this has been found in literature. Occupation, in terms of people who work in soil and muddy fields, farmers, they are more prone to get this infection. And warm climates have been found to be a risk factor for this infection. Coming to whether immunocompromised, if only immunocompromised individuals are affected, well, the answer is that from this study in 2012, it was found that acanthamoeba is considered the most likely caused in immunocompromised individuals, while Balamuthia mandrillaris is seen in both immunocompromised as well as immunocompetent individuals. In a study from 1974 to 2016, titled Epidemiology and Clinical Features of Balamuthia mandrillaris, out of 109 case reports of this disease, 99% in the US had encephalitis. And the median age was noted to be 36 years, and it could range from 4 months to 91 years, therefore showing that there is no specific age group that could get Balamuthia mandrillaris. The clinical course of this disease ranges from several weeks to months. It starts off in most cases with the appearance of cutaneous lesions, which are painless, non-ulcerated plaques, usually more common on the central portion of the face, though other parts of the body, such as the extremities, mandible, and abdomen, can be affected. It then proceeds on to CNS disease, causing encephalitis, decreased GSS, poor tone, and eventually coma and death results due to the increased intracranial pressure, brain herniation, or from secondary infection and multi-organ failure. These are studies that highlighted how these nasal lesions look like, and it's been found that it's most commonly a centrofacial skin lesion. As we can see in the top picture, it was taken from a child in Peru. And in the picture below, it's an immunocompetent school-aged girl who presented with cutaneous lesions over her nose. In a case report in 2020 from China, where 28 cases were reported, it was found that 97% of cases were from rural areas, and most of these people had trauma, either from by accidental trauma falling down or by exposure with soil in working in fields. It was also found that in 57% of cases, encephalitis developed, but in most cases, they presented firstly with skin lesions. And follow-up information was available in 96% of cases, luckily, as the treatment rates were successful. Among this, 56 patients, however, died due to encephalitis, and 44% were free of disease. It is to be noted that in these Chinese cases, encephalitis developed 3 to 4 years after skin lesions, while in US reports, it is said that the people infected with Balamuthia mandrillaris present first with encephalitis and then skin lesions. These are pictures of the children affected with Balamuthia mandrillaris, and we can note the indurated red plaque. And coming to amoebic encephalitis, an MRI is usually the mode of investigation, and this shows in 40% of cases frontal lobe lesions, as we noted with our case also. The definitive diagnosis, according to literature, is real-time PCR, immunohistochemistry, indirect immunofluorescent assays of brain biopsies, but these diagnoses are quite rare and require resources. Of note is that if one considers a lumbar puncture for CSF examination, Balamuthia mandrillaris is rarely found in CSF. But if ever a CSF examination is done, one would see 40 nucleated cells per high power field, slightly elevated protein, borderline glucose, and several motile trophozoites with pseudopod formation, and that would lead us to the diagnosis of amoebic meningitis. Balamuthia mandrillaris has a very poor prognosis. The reason being a low incidence, non-specific findings, and delayed diagnosis. It is found in literature that less than 10 documented survivors out of 150 reported cases of acanthamoeba was noted, and for Balamuthia mandrillaris, 10 survivors out of 200 reported cases was noted in the US. Treatment options, there is no specific treatment till date that has been found. However, we use a combination of drugs, which includes fluconazole, albendazole, atraconazole, pentamidine, propamidine, isotoniates, polymyxin B, and gramicidin S. A study in 2015 showed that miltefosine has good blood-brain barrier penetration and is therefore used in granulomatous amoebic encephalitis due to its anti-leishmanial, anti-neoplastic, and in vitro amoebicidal activity. And indeed, for our patient, we've ordered miltefosine. Other literature review in 2018 found that the quinolone nitrozoline was potent for Balamuthia mandrillaris, as it inhibits both the trophozoites as well as the cysts at low micromolecular concentrations. And it is quite a good drug because we use it commonly for UTI, and now this nitrozoline can also be used for Balamuthia mandrillaris. In a paper in 2011, where a rare survivor of Balamuthia granulomatous encephalitis was treated, they basically classified the agents and treatment as acute treatment and ongoing treatment. For acute treatment, pentamidine 4 milligrams per kg per day IV was started alongside with flucytosine, fluconazole, and sulfadiazine, and an ongoing clarithromycin and fluconazole was continued. So as conclusion, one should always be able to detect such skin lesions and prompt biopsies and interventions are required in order to avoid the high morbidity that is accompanied by such infection. Dermatologists, otorhinolaryngologists, pathologists, pediatricians, and neurologists should be alerted to this rare disease when diagnosing unexplained granulomatous skin and nasal lesions. And indeed, a multidisciplinary team is always a success in dealing with such rare cases. These are my references. Thank you for your kind attention. Are there any questions?
How's the child doing?
Do you want me to answer that, Divya?
Yes.
Thanks. That was really nice. A really nice comprehensive review of a very rare condition. Prof, in the literature, you'll see that 99% of them go on to have meningoencephalitis. So it's very unfortunate, but consistent with the progression of this condition, that she's actually got a GCS of 8. She ended up having seizures on Saturday and seizures again on Tuesday, but no raised pressure. She's on anti-epileptics, but she's not able to feed or communicate. She's an M5, but she's nasogastrically fed. So even though we know this is the progression of the condition, it's just, for me, just absolutely crazy to have a complicated sinusitis come to us. Just like that. This is a complicated sinusitis, please manage further. But there were so many markers for this child that just didn't add up. And we felt it quite necessary to present it on this platform. One, because, you know, things may not always look as they seem. And two, this is quite rare, but there are many places in Africa that have a lot of knowledge about amoeba, as well as about the treatment options that are available because of the parasitic background. So we thought it was important to present. I don't know how she's going to do, but we're going with active management at least for another week, because we only got the miltefosine on Tuesday, and the World Health Organization sponsored it. So we'll see. It's an oral dose. It's not allowed to be used for people under 8, but she's 3.5. And so we're also using it for that. So there are lots of variables that we have to worry about, but we can't just let her die. Sounds morbid, sorry.
Sorry, Divya, I missed the first bit of your presentation. Did this patient present quite acutely?
Yeah, she
Yes.
presented as a complicated sinusitis to us.
So the other differential that that would have gone through my mind, I think, had I seen this child, is a neck fasc, like a necrotizing fasciitis. I mean, that's just the other, you know, that thing that I would have probably have thought of, but I think going against that is a white cell count that was normal. And in fact, she didn't spike the temperature. Hey, she wasn't paroxysmal.
But it could have, you know, it's definitely part of the differential, because when you look at the skin changes, she had local swelling. So it was erythema and swelling. And we didn't know how long it was like that. So it could easily, I would agree, it could be part of that differential. I mean, when we read up on it subsequent to, you know, to knowing that this is something else, and it looks like all the other pictures, it's very common in Peru. And you see all the kids there present the same way. But yeah, for sure, from in our setting, I would always think of TB and rhabdo, and many of the common things that we see that progress quite dramatically. But we knew this was something else. We just couldn't tell what it was. And I think the main thing that we struggled with was getting the biopsy and the positive result. And the one thing we did do was consult the head of dermatology, Prof. Hlela, and they suggested the skin biopsies. And we're usually quite cautious with, you know, taking tissue biopsies on the skin. And so they just used a punch biopsy straight wham onto that skin. And what we did was we were informed by the NICD, the head of the NICD, to just put it in a dry container because saline can affect it. So that was how we got the diagnosis. And the test is a PCR test, but it's not validated, so it's 70% accurate. But that, together with the histology, is in keeping with it. So it's just all so rare.
Thank you, Prof. I've got a question here. I think this is the child that I admitted. When she came in, when we did that CT scan, we thought those were fractures, and we were actually going to consult the child protection unit to find out what had happened to the child, because we thought someone might have assaulted her, because she was not staying with the mother, she was staying elsewhere. But then I noted in Divya's, one of the studies from China, that actually 61% of the patients who had the condition actually suffered trauma before. So I was wondering, where does the presentation tie up with the way they present, like those changes on the CT scan that we thought were fractures? Was it actually the way the disease presents, or it was actually the effect of the pathological progression of the disease?
So from this child specifically, we did exhaust that avenue, and we didn't find any evidence of non-accidental injury. So for our case specifically, I don't think we could say that there was a pre-existing trauma to it to say that. I think, Divya, if you want to answer from the literature whether you have to have a history of trauma first or not, but certainly wasn't the case in our
Yes.
patient.
Yes. That was just from China, that it was found in only 28 from 28 cases that 96% had a history of trauma, but otherwise in worldwide it's not a predisposition that you need to have trauma in order to get this infection.
But that is significant enough, though. I mean, if you're saying 96% of all the kids from China, the Chinese study,
Yes,
that means that's almost all of them.
yes.
So it would be worth looking at it. But the microbiologist from our side said that amoeba is in the water everywhere, and it's in the Eastern Cape, and there's no risk of, if this child maybe is immune competent, it doesn't necessarily mean because she's immune compromised that she's, got it. So she was quite comfortable to say it's everywhere. It's not, this child offhand doesn't have any predisposition, including trauma, but it is something worth mentioning. I wanted to ask Charles if he's online, whether he wants to add anything. I know he was at the MDT yesterday, just in terms of the prognosis and where specifically we are with the drug, and whether he has any input. Charles, if you have anything to say.
Thank you, Prof. Yeah. So I had the privilege to also attend the MDT that we had about this patient yesterday. So present with us, the ENTs, the ICU team, infectious diseases, neurosurgeons, and the pediatricians. And then a few points were raised. One was that there was a clinical deterioration due to one, there was the GCS has gone down from initially 15 to 8. And the other issue was that this child has also developed seizures. So because little was known about this disease, and also the medication that we got from WHO, so it wasn't clear if this cause of the seizures and also deterioration in terms of the neurology, was it due to the clinical progression of the disease, or was it due to the side effects of the medication? Though I think one of our colleagues from infectious diseases, from their experience with treating leishmaniasis, said it's common that this drug, miltefosine, can cause dizziness, but seizures were rarely reported according to his experience with leishmaniasis. So yeah, those were some of the issues that were raised, and we also tried to look at the prognosis of this patient. And again, because of the paucity of data in terms of literature, we were not sure if, in terms of how the natural history sort of like of this condition presents, whether do they deteriorate before they get better, or it's just disease progression and things can only get worse. So those were some of the issues that we really raised. And the other concern was, looking at the prognosis, which was not so clear, if this child deteriorated, were they going to be a candidate for ICU admission? In view that we had already started them on metformin. Yeah, so I think the decision from that MDT was that we decided to do a CT scan just to make sure if there was something which can be addressed from a neurosurgical point of view. Because initially there were these micro or small intracranial collections which were really not drainable. So, and the neurosurgeons were prepared to check the child for data for drainage if there is any drainage collection. And then the other issue was that we had to try and address any other cause of either seizures or clinical deterioration and do baseline blood investigations like blood glucose, make sure the child is not hypoglycemic, and do urea and electrolytes just to make sure that is also in control. And I think the decision was to give this child a chance, since we're not so sure about the disease progression, and actively manage. So I think that was that. And then the plan going forward was that after we get the CT plan, and then we will sort of like sit on another MDT on Monday, reassess the child and map the way forward. Apparently, the child had a CT brain done yesterday, and there is definite disease progression. There are now more numerous micro collections, but nothing really. They are so small that our neurosurgical colleagues can't really drain. So yeah, so that was sort of the outcome of the discussion, and I think a subsequent MDT will be done on Monday to map the way forward.
Thanks, Charles. Yeah, so I think that was also one of the reasons why I thought let's present it at this forum, because maybe somebody in Africa has more knowledge about this. But two things was, could we have done anything differently in the course of events? And I think the one reassuring thing is her sinusitis resolved, but she had ongoing disease which progressed to the meningoencephalitis, which is continuing to basically compromise her. And the second question is, to what end do we continue to actively manage this child where it becomes medical knowledge gained, but not healthy for the child and the family? So this is where we're going to get to hopefully this weekend. Thanks everybody for your input. I don't know if anybody outside of our borders somewhere has anything to add from up north, maybe if they've had an experience like this, or even if they managed leishmaniasis. I believe it's very prevalent in Ethiopia, and they know about the drug that we're using, miltefosine.
Shazia, can I ask you a question? Jos
Yes,
Ella.
sure. Hi.
Good morning. So tell me a little bit about how it was, the amoeba was actually first discovered in this case, or was it just on the HNE?
Well, so we had lots and lots of specimens sent through, and initially there was just granulomatous inflammation. And I think on one of the slides, we actually got Prof. Pillay Kumala involved, and she then looked at all of them. And based on, we'd sent her pictures of the scans and pictures of the child. And on one of the slides, she found something that looked like an amoeboid type structure. And so she was quite suspicious that this is amoeba. And she'd gone through everything and excluded everything, and was concerned that this is amoeba. So we then did directed biopsies and specifically looked at the skin, and then sent all of that off. And there was a case that was, it's a very long time ago, a child who died of meningoencephalitis, and the results only were found on post-mortem. So I think she'd had that on her radar, and this child just was so not any of the other things, it just didn't fit. But this fitted well, and her clinical picture sort of made us sit up and say, hang on, this is something different. So she actually was the one who thought of the amoeboid by picking up that one marker on one of the slides.
Yeah. And this was the skin affected clinically?
Sorry, say that again?
The skin, was it affected clinically?
Yes, yes. You look at the picture, you can see it, and I
didn't
think
see
that's why
that.
we got. Oh, sorry, we'll send it to you. We can maybe Divya can just share it. You can see on the bridge of the nose and across the nasal skin and extending onto the ipsilateral cheek.
Okay. Oh yes, yeah.
Yeah, and that's all healed now, which is quite also quite unusual. Her skin's healed and everything, but it's just progressed into her brain.
Yeah.
But the mediums are very specific, you know. So even if you just, you know, like Darlene, like Tashneem is saying, you know, you have to have your regular garden variety differential, and you test for that. But if you've got markers for unusual things and all of that comes back negative, then you start testing for the weird and wonderful, but have a suspicion of it because the child doesn't particularly present typically. So this would have been on the second sort of testing ground, you know, but we would normally just send off for what we think is common.
And she has a sort of non-specific history. In other words, she, I don't know, obviously, whether she been swimming with her mom or whether she been bathing or.
Yeah, so they have a river. She stays
water.
with Granny in the Eastern Cape, and they live near a river in an informal settlement.
Okay.
Yeah, no dog bite, no history of any of that. But that, as the microbiologist says, you know, it's a public health nightmare. But all of the water in many areas in South Africa has amoeba. All of the water.
Yeah.
Yeah.
And she's not particularly immunocompromised.
No, HIV negative and otherwise healthy. She's only
Healthy.
3.5, but she's never presented with anything in the course of the 3 years, and not particularly not malnourished, no, not more so than our usual kids. And and she actually, you know, we said if she does make it and she does progress in a positive way, or improve rather, where they would do primary immunodeficiency testing, you know, just to see if there is something there. But there is no reason to do all those tests now if it didn't change management.
No.
Yeah.
Well, the question is, how much is not diagnosed?
True. How many
And
kids come in with
that what worries me, you know, is that how much is missed, and obviously the big contender here is what we need to think about is obviously your fungal infection, you know, the aggressive ones. That obviously is a differential.
Yes. Yes.
So, but we never think about. I've never thought about amoebic infection in, you know, the sinonasal area. So the question is, how much didn't we see, and how much is there really around? And can it also affect other areas of the body, like skin, feet, legs?
Yes. Yes.
It does.
Yes, it does. So the studies have, the most common is in the central portion of the face, mandible, extremities, elbow. They are also affected, but just that they say that most commonly it's the face.
Okay.
Also, I wanted to add that in the literature reviews, I noted that in some places they went for brain biopsies, and just to excise the lesion in the brain, though it's not recommended, but in few studies it's been found that taking brain biopsies had led to recovery. But that obviously would be if it wasn't that extensive and if it was minimal.
Yeah, I mean, I don't think we'd be doing that.
For our case,
Okay, thank you.
Sure.
Thank you so much, Divya. Is there any other questions? Okay, I'll end off this meeting. We'll see everyone again on Wednesday morning at 7:15. Thanks so much for joining in.